Research. Thank you. It's now my pleasure to introduce Dr. Fred Nicholls, who will enlighten us about the importance of the Calgary Normative Spine Database. Dr. Nicholls is an orthopedic surgeon specializing in spine surgery with a focus on complex trauma and spinal deformity. As resident education lead and director of the Spine Fellowship Program at the University of Calgary, he also trains future spine surgeons. Please join me in welcoming Dr. Nicholls as he shares his research and insights on spine health.
Thanks very much. Welcome, everybody. Thanks for inviting me today. So Dr. Swami just talked to you about how spinal diseases start and how he's working on preventing them from even happening in the first place. Dr. Kadot later on is going to talk to you about how we predict who will end up needing the services that we provide. We're all looking to the future. It's, after all, why we do research, to affect the future of the field we are dedicating our lives to. I will speak to you more about trying to change the way we perform the surgeries themselves. The more immediate future, the future that Dr. McWay is going to talk to you about potentially preventing. There have been a lot of giants in the field of spinal deformity surgery that have established themselves, showing us how to shape the spine, what the shape of the spine is, and how we hold it there when we're finished with our surgeries. These are geniuses, and they've changed the lives of millions of people. All of them have been right, but somehow they have also all been completely wrong. So this might be controversial, but if they are completely right, how is it that we can perform procedures exactly to their specifications for every available metric, and yet still have patients that are either unhappy or whose surgeries fall apart? There are now an entire series of different theories for what shape we should hold the spine in. Some of the criteria we've used include simple angular measurements, while others strive to provide an overall description of the shape of the mid and low back. Some consider averages for populations as a whole, and some, in turn, are highly categorical. We know that the truth is likely more individualized, and yet we struggle to identify what the defining characteristics are. Maybe that's because we have to choose a position in which to leave the spine when we're done, whether that be a position that's more suitable for standing, maybe one for lying down or sitting, or one that's more suitable in turn for activity. What you will notice when you're looking at some of the attempts at defining the shape of the spine that I put up just before is that they all kind of end at the shoulders. I realized as I was fusing people's necks that the exact shape was very poorly described. I spoke with Pierre Roussely about his work defining the shape of the spine and asked why he hadn't extended it up any higher. He told me that there's just too much variability and he could never get enough volunteers to clearly show defining patterns. So I may not be capable of abstracting the true nature of the shape of the spine, or I may not have been able to see as many patients yet in my career as he has in his kind of storied career to this point. But one thing that I can do is put together a bigger group of people to look for those patterns. And so that's what I set out to do. Part of the reason that I'm able to do that work is the supportive environment that I'm lucky enough to work in. When I expressed an interest in studying this, my colleagues offered a lot of support, knowing full well that it may take decades for me to answer some of these questions. I've spoken at multiple institutions about the concept of academic medicine and the environment in which that occurs. We're extremely lucky that through the support of the McCaig Institute, our institution has a greater interest in fostering the academics that work there's own interests over simply volume or productivity. So I set out to recruit this large group of healthy volunteers and obtain imaging of their entire skeletons. I found software that would allow me to synthesize the shape of the spines down to Cartesian coordinates, future-proofing my database such that we would never have to remeasure if we could do it properly the first time. The first thing we were able to do was validate Rousselet's categorical descriptions of the different shapes of the spine and the distributions of those different shapes through our population. We then started taking a look at how that shape extends up into the neck. And what we found very quickly was that there wasn't really a direct association, and we ran into a bit of a hurdle there. And the McCaig was able to connect us with machine learning experts that took us on a different route to looking at how the shapes of the neck were categorically separated. We've been able to define 3 separate shapes for the normal cervical spine. And what you'll notice is that only one of those groups follows the very classically defined C-shaped curve of the cervical spine, and that 60% of people are walking around with a little bit of a hitch in the middle. Not only did we look up above, but we also looked down below. There has been a long-standing disconnect between hip surgeons and spine surgeons. However, invariably, the kind of people that develop arthritis in their backs also develop arthritis in their hips. And what we've noticed is when we change the shape of people's backs, it sets the position of their hip differently, and they can frequently have their joint replacement fall apart. We've taken this same database of young, healthy people and been able to show a relationship between the way the spine takes off out of the pelvis and the shape and location of the cup portion of the hip joint. We've also been able to take long-standing, dogmatically held understandings of the shape of the low back and how it comes off the pelvis and show that uniformity isn't really an actual thing. There is a huge distribution amongst the normal population, and that maybe one of the reasons that we're failing with some of our surgeries is we're all trying to correct to an average ideal instead of moving more towards an individualized shape for the low back. We've even been able to take some of the most modern ways of looking at posture and balance in people and show variety and distribution across the population. Now what we're trying to do is look at people in a longitudinal sense. One of our biggest criticisms when we've been trying to publish this work and release it is that how do we apply a database of young, healthy people between 20 and 40 years of age to the people that most frequently suffer from these problems, who are much older? And so we were able to link up with another group of researchers in New York who have a much smaller but wider age-ranged group of volunteers and show that before 50 years of age, we don't see a lot of difference in the shape of the spine. So we started thinking, what sort of life events might occur between 20 and 40 years of age, or even 40 and 50 years of age, that could lead to that degeneration and change in alignment parameters? One of the first things that we've hit on is pregnancy and childbearing, and we now have a large study underway bringing back the women in our study to see what sort of changes in the shape of their backs and the shape of their pelvises occur with childbearing, both on a temporary and on a permanent level. We are also adding granularity to that data. We've developed an app that passively collects activity data on the subjects of this study and feeds it back to give us context on how exercise may affect the development of degeneration. I think Dr. McWay is also going to talk to you about that. We all have a relative that lives to be 90 without ever looking after themselves. And so how exercise relates to degeneration remains a little bit unclear. By no means am I one of the giants that I showed you earlier. I do this research so that I can gain a deeper understanding of the alignment and shape of the spine. It's my hope, though, that this work will serve future generations of spine surgeons and allow people to learn without having to repeat the work that I'm doing here. I recognize the value of this data, and I know that I could probably monetize that by selling it to some insurance company and maybe even retire at the end of that, but I choose not to do that. The reason that I'm allowed that choice is because of the assistance that all of you provide. And I hope that one day I'll foster a better understanding of the natural shape of the spine, how to achieve a shape that resists failure and allows people to participate in all of their desired activities without compromise. We're getting closer, we're tightening up these distributions, and by the next opportunity I have to come and speak with you, I expect that we'll have a little bit more clarity. Thank you.
Thank you, Dr. Nicholls, and we look forward to your return visit very much.